Hello everybody and welcome back to my channel. For viewers who are new to my channel, I'll just give a brief introduction for them. I am Triya and I am a PhD scholar at IIT Kanpur, and I generally post videos and lectures on tissue engineering, regenerative medicine and its associated topics. So previously I have posted few lectures and sessions on the basics of tissue engineering and some of its important integral parts, which are the cells, the extracellular matrix interaction, and the scaffolds. Now in this lecture, we'll talk about the tissue graft and the rejection process. So I think all of us are aware that when something is implanted or transplanted into human body, it results into certain reactions and rejection process. So in today's lecture, people will get to know the basics about the rejection process and how the body reacts when something foreign is implanted and how finally it results into certain reactions. So with this, we'll start today's lecture. First, I would like to talk about what transplantation is. So many of you are already aware of transplantation and what transplantation is. But for the simplicity and for understanding of the other viewers who are not that aware about transplantation, I would just give a brief introduction about it. Transplantation refers to the transfer or like movement or transfer or giving of living cells, organs, and tissues from one part of the body to another part of the body, or from one individual to another individual. So there are multiple types of transplantation that are possible and that are currently being done. So I will describe and I will give basics about it in my next slides. For basic understanding, transplantation is simply the giving or the transfer of living part from one part to the other part. Next, talking about some of the major applications or major organs that are transplanted in like near future and in also recent days. So the main organs include the kidney, the heart, liver, then cornea, then pancreas, finally bone marrow, small bowel, and skin. So the list shows here the major organs which are being transplanted. So I will basically go into each of it. For the kidney, it is basically and it is mostly done for patients who suffer from the end stage kidney or renal failure. Similarly, for the heart transplant, it is majorly being performed in the patients with terminal cardiac failure, followed by liver transplantation into the severe and end-stage disease patients of cirrhosis and cancer, which is the chronic stage of liver disease, and then a further dystrophy in case of cornea, and sometimes diabetes leads towards complete failure of pancreas and loss of functioning of the islets of pancreas. So in case of diabetes, patients who are suffering from critical and end stage cases, for them pancreas is also transplanted. Further, in case of immunodeficiency diseases like leukemia and other of such diseases, bone marrow is also transplanted. Further, in case of severe burns or injury or deep cuts, in those cases where the epidermis and dermis and all the layers of skin are damaged and it requires external help and acid attacks. So there can be several of the such examples. So for them, skin is also being transplanted. talking about several barriers or hindrances to transplantation, because in order to understand the science behind it, it is important to understand and know about several barriers and certain differences which takes place. So in this slide, I'll talk about the different type of grafts or transplants that are possible. So majorly and commonly, there are four types of grafts that are currently in use. So these are the autografts, the isograft, the allograft, and the xenografts. So talking about the first category, which is the autograft. So autograft refers to the like a transfer of organ from one part of the body to another part of the body, but of the same individual. So from the same individual, it is transferred from one place to another. So there is no differences in the individual, because it is its own body part is being transplanted. Moving on towards the isografts. So isograft refers to the transfer of organ from identical individuals. So for example, in case of monozygotic twins, and in those cases, if transplantation is being taken place or transfer of organs or tissues is being performed, then that is known as isograft. Moving forwards to the third type, which is the allograft. So allograft refers to the transfer of living tissues, organs, or cells from genetically different individuals. So they can be unrelated individuals, but they are of the same species. So you can take an example, like in case of two humans, if kidney is being transplanted or cornea is being transplanted from one individual to the other individual, so genetically they are not same, because they are from different origins and different paternal origin, but they belong to the same species, and therefore these are known as allografts. Further, moving on towards the last category or towards the last type, which is xenograft. So xenograft is transfer of organs or tissues in between members of different species. So this in this case, the species is also different, not only from one individual to another, but also from different species. The transplant is being performed. So in this case, there is a rapid and very fast rejection by the IgM antibodies or the cell-mediated rejection process. Further moving forwards, so the slide which is currently visible, it gives the overview about already explained the different types of grafts, namely the autograft, the isograft, allograft, and the xenografts. So as already described in the previous slides, so these are the different types of graft. Coming or talking about the first category or first type of graft, which is the autografting. So autografting refers to the auto or the transfer of the cell tissue from one part or from one side of our body to another side of our body, but of the same individual. So the person, it remains the constant. Further, the genetic homology, or due to the genetic homology of the tissue, the immune system or the immune responses does not take place, and there is no such adverse immune reaction, because the transfer is from the same individual. Some of it includes the skin grafts, the bone marrow transplantation, and the hair follicle transplantation or the hair transplant. Further, moving forwards towards the second type or the second category, which is referred to as the allograft, or the process is known as the allografting. So, talking or getting an overview and details. So, it basically is the process of transfer of living tissues, organs, and cells from one individual to another individual. So, in this case, the organisms are different or the individuals are different, but they belong to the same species, as already explained previously. So, as there are more and more people every year, there is a huge waiting for donor organs and for tissues, and thus allografting transplantation has become in recent years quite a common. And the allografting transplantation also has several other applications. Further moving forward towards one of the most vital topic under this craft and transplantation, which is the immune system rejection. So it has been seen that often a transplanted organ is not identified by the person's or the individual's immune system as its own tissue or organ, and thus it is the immune system of our body that is being developed, that it will attack and destroy the foreign material. So, against this attribute or against this effect, the patient has to swallow immunosuppressive medicines that lowers down the immune responses for that time being, so that the transplanted organ or tissue is not destroyed and it is not harming the individual. So in 15 to 20 minutes, the organ dies and it is unable to withstand the immune system attack. So our immune system is developed and evolutionarily evolved in a way that it protects our body from foreign particles and from other microorganisms, bacteria, virus, and others. So hence we have to keep this point in our mind, that whenever a new or foreign object or a foreign material, tissue or organ is implanted into another individual, so the immune system will not recognize it as its own, and therefore will result into attacking of that particular area or organ, which ultimately leads towards very fatal consequences, and often leads to death of the individuals who have received the transplant. Talking about the rejection or the rejection of graft, also known as graft rejection. So there can be first a set of rejection followed by a second set of rejection. So the graft rejection, it is a kind of specific immune response, and that really needs the specificity and the immune memory of it. So these are a few requirements or necessities that are required for the process. This slide, which is visible right now to all of you, shows the first and the second set of allograft rejection. So as it is seen that if a skin graft is considered, so in case of the three images, which is the image A, the B, and the C. So in case of image A, so the donor, which is shown in a green column, so that is a strain A. And similarly in case of other two donors, which is in case of B and in case of C. So basically when a skin is implanted onto a different individual but of a same species, And further, the recipient, which can also be considered as a strain B, is then sanitized by the previous graft from a strain A donor. And similarly, in case of C, the recipient, which is the strain B, is injected with lymphocytes from strain A animal, and that has been rejected in strain A. So basically, it is a seen that in case of the first column, that there is graft rejection in the day 3, which is the first set of rejection, followed by in other two parts, which is the image B and C. There can be seen the second set of a rejection. Moving forwards, now we'll have a discussion about when the graft is accepted and when the graft is rejected. So now we'll talk about the acceptance of an autograft, and which is generally completed within a time frame or time duration of 12 to 14 days, followed by first set a rejection of an allograft that basically begins from 7th to 10th day after the grafting process is being completed, with full injection that occurs by day 15 or a day 10 to 14. And also I'll discuss about the second set rejection of an allograft that begins within 3 to 4 days, with a full rejection that can take place by the 6th day or the 5th day. Further, the cellular or the cell can infiltrate and also invade the allograft, and along with the lymphocyte, the phagocyte, and other inflammatory cells. So as it is seen that in case of autograft, there is, if suppose there is a grafting or implantation or transplantation of the graft, which is the epidermis, and that results into series of sequential reactions, including the revascularization, the healing, and followed by the resolution. Further, talking about the first set of rejection, so in case of allografts, so upon the epidermis grafting, or the upon the grafting of the epidermis, it also leads into revascularization, but it is followed by the reaction, and in this case the cells from the neighboring, it infiltrates into the grafted area, and further it leads towards a development of a thrombosis or also a necrosis. Moving forward towards when and how does the second rejection happens. So in this case, upon the epidermis grafting or upon the epidermis graft is being performed, that again it leads it leads towards the infiltration of the neighboring cells, or the cellular infiltration, higher number of cellular infiltration, that further leads towards the thrombosis and the necrosis. So basically it leads towards a development of necrotic tissue. So I think with this slide, it is clear for everyone that what are the immediate steps that happen upon a graft and upon transplantation. So in this case, we talked about the skin graft. So in with that, we have looked upon the several sequential consequences that occurs upon the transplantation or on completion of the uh, grafting. Further, now we can wonder that if any allograft is rejected, then what are the types of it? So now we are going to talk about the classification of allograft rejection, which are basically of two types. The first one is the HVGR, which stands for the host versus graft rejection. So basically, it is a seen in the conventional organ transplantation cases, which is that what the host faces upon the graft rejection, or what happens to the host when the graft is rejected, or what is the reaction of the host upon the graft or the transplantation. The second type is the GVHR, which stands for graft versus host reaction, where it is seen from the perspective of the graft that what happens upon the host reaction to the graft. The classic examples include the bone marrow transplantation cases, and also the cases where the immune cells are grafted, or basically when they are transplanted. So, discussing about the first type of reaction, which is the HVGR, which stands for host versus graft rejection. So there can be several reactions that can be seen after grafting the transplant, which can be hyperacute rejection, or it can be acute rejection, or it can be chronic rejection. So these are the three main types of rejection that are generally found in the host upon grafting foreign material into the patient. Now you will be thinking that I have only mentioned the name. So in this slide, I'll be describing what actually hyperacute rejection is. So basically in this case, the graft is rejected within minutes to hours because of the presence of vascularization. Actually, the vascularization is rapidly destroyed, and thus the graft is rejected within a few minutes or within a few hours of the transplantation or upon the graft placement. So it generally occurs because the recipient is the one who receives the implant or the transplant, and in this case the recipient has pre-existing antibodies. So there are already presence of antibodies from some previous exposure in circulation against the graft. So our immune system is developed in a way that any foreign material is attacked by our immune system with the help of antibodies and other several innate and adaptive immune components. So in this case, against the graft which is being transplanted, there is there is presence of antibodies which attacks the graft, resulting into the destruction of the vascularization. So the antibodies basically they bind with the donor endothelial cell, and the antigen and the antibody complexes that usually form in any case, and in this case also the antigen they bind with the antibody and they form certain complexes that tend to activate the complement system. So there are several components of immune system. One of it, which is the innate system, it consists of the complement system, and that complement system results into activation of the complement system results into causing the massive thrombosis into the capillaries that prevents the vascularization of the graft. And for example, kidney is the most susceptible to hyperacute rejection. So this slide shows the diagrammatic representation of what I have explained in the previous slide. So as it can be seen, and I've already mentioned, that it attacks the endothelial cell. So basically, there is a resulting, the final thing is thrombosis. So basically, when there is preformed antibodies, it results into activation of complement system, thereby resulting the margination of the neutrophil cells, which results into inflammation and further resulting into thrombosis. So finally, thrombosis is formed, and that results into the rejection of the graft and resulting into acute rejection of host versus graft reaction. Further, discussing about what acute rejection is. So, in case of acute rejection, there is the vascular and the parenchymal injury that is being carried out, or that is facilitated or mediated by the T cells and the antibodies, which are the adaptive components or adaptive immune system components that are present in our body. And these T cells and the antibodies, they basically begin after the first week of transplantation. So they generally get activated and they get signals about something foreign that is being detected in our body. And if there is no immunosuppressant therapy, it tends to get activated after the first week. So in this case, the incidence is extremely high. So the percentage of occurrence of it is around 30 to 35%, which is considered quite high for the first 90 days, which is around 2.5 months. So 2.5 months, 3 months. So for any patient who has undergone any transplantation, the initial 3 4 months, even the initial few hours, they tend to be very critical and crucial. So during the first initial 4 months, it becomes very important and vital to take care of the patient and to see that whether any rejection is not occurring, and heavy doses of immunosuppressant are being given so that the immune system is suppressed and it is not able to perform thrombosis and any other fatal reaction that can cause harm to the patient. So if the first few months and even few hours, initial about 2 3 days, those time is like surpassed, and then it becomes very important that the transplant then becomes successful. So the initial few hours is extremely important for the patient and for the doctors to take care of the patient. And if those few months are being passed away and surpassed, then the patient has a successful transplantation record that results into increasing the life expectancy of the said or of the said individual. Moving towards further details about the acute rejection, which I've already mentioned briefly in the previous few slides. So basically, it is a combination of the innate and the adaptive immune system components. But majorly in case of acute rejection, the adaptive immune system takes active part, which includes the T cells and the B cells. So the B cells, they generally synthesize or they produce the antibodies. So in this case, the antibodies and the innate immune component of macrophage, again T cell, they act in combination to result into the rejection process, or they actively participate in this reaction. There is a resulting of the myocyte and the endothelial damage that results into inflammation, and that further leads towards destruction, and there is damage to the blood vessels, and that results into thrombosis. Now, after getting sort of an idea about the acute rejection, we'll move forward towards understanding the other severe reaction, which is known as the chronic rejection. So, in this case, like the case of In acute rejection, it was all about grafts. So suppose if it is a skin graft or something which is a graft sort of. But in case of chronic rejection, it tends to occur in most of the solid organ transplants. So in case of any major organ transplant like liver, kidney, lung, heart, chronic rejection occurs. So basically, in case of acute rejection, it was characterized by thrombosis. So in this case, the chronic rejection, it is basically characterized by fibrosis and vascular abnormalities that results in the loss of the graft functioning over a prolonged period. So, chronic rejection is one of the deadliest sort of immune reaction upon any transplantation. Thus, it becomes critical for the doctors to uh, carefully tackle it, and sometimes in majority of the time, not sometimes, like major of the cases, the patient dies because of the transplant rejection. So the body, even after several checks, when the organ is being transplanted, the body is not able to accept it as its own. So if you can imagine that all of our organs, all of our cells, they are tagged. So if you can imagine that it is being tagged with a particular color. So when something different tends to get inside the body, our immune system, like within very few minutes and within a short period of time, it recognizes that it doesn't have that tag, which is suppose a green tag. So not having that green tag results into attacking of the other immune cells to that foreign material. So the immune system is both advantageous, is obviously required, but that is something which plays a major failure, it results into failure of the transplantation. So this acts as a negative side in case of transplantation. So it becomes very important and it is very critical to make the body understand that yes, it is our own part, or it is our own organ. So that is a very tricky process, and it takes months for it to get accustomed to it. Thereafter, going into certain details about what happens during the chronic rejection. So, as in case of acute rejection, here also both the innate immune system and adaptive immune system of our body comes into play together. So, it is basically mediated by the macrophage and the T cells, and there it results into the concentric medial hyperplasia. And further, there's also cases where there are chronic delayed type hypersensitivity reactions. So there is a cytokine storm, to be specific, in case of chronic rejection. So the vascular smooth muscle cells, they are affected, and the antigen antibody complexes that are formed, that results into a release of several cytokines that attracts the other immune cells, like the macrophages and the T cells. And once the T cell and the macrophages, they come into the picture, that results into the vascular smooth muscle cell destruction, ultimately leading in the reaction of the chronic rejection. So after getting an overview about the acute rejection and the chronic rejection, we will see and we will understand that how it can be prevented and what are the therapies of the allograft rejection. So now, for any solution, it becomes important that we understand what the problem is. So likewise, in today's lecture, or in this class, I have first mentioned about the various problems that can occur and how they can happen, and how what results into this, and what are the consequences of the graft and the transplantation. So I have already mentioned about this, the acute and the chronic rejection. Now I'll talk about that how it can be prevented. So if there is problem, there can also be solution. So how it can be prevented and what are the therapies for allograft rejection? As I think people have idea that before any organ transplantation, there is a very strict and severe checking and assessment in order to find the ideal donor. So it's not something like anybody's organ can be transplanted into any other individual. So there are several therapies and several assessments that are made prior to do any organ transplantation. So now I'll be talking about those. So the first one is that any tissue which is the desired tissue that undergoes the tissue typing assessment. So it can be described as the assessment that checks the immunological compatibility of the tissue from various separate sources, and this is actually being carried out prior to the organ transplantation in order to find the suitable and the ideal donor. So then after the transplantation and before the transplantation, there is immunosuppressive therapy of the patient. So prior to the transplantation, the patients are given with several immunosuppressants that function or that act by lowering the activity of the body's immune system, that comprises of the innate immune system that consists of the neutrophils, macrophages, monocytes, and also the adaptive immune system that comprises of the T cells and the B cells. There is also something which is known as induction of immune tolerance. So, immune unresponsiveness that are generally specific to a particular antigen or set of antigens is basically induced by several previous exposure to that antigen. So it is very important that all of you understand that there is several checks and pre strategies that are performed and therapies that are performed before the transplantation in order to make that patient suitable to accept any other foreign organ from other individual. As it is visible that this slide shows several drugs and several antibodies and how it acts in order to suppress the immune system. So talking about the first one, which is cyclosporin and FK506. So it basically blocks the T cell cytokine production by inhibiting the activation of the transcription factor, which is the NF18. Next, moving on to the second drug, which is mycophenolate mofetil. So this acts by blocking the lymphocyte proliferation, thereby inhibiting the guanine nucleotide synthesis in the lymphocytes. Further, the another widely used drug, which is rapamycin. Rapamycin acts by blocking the lymphocyte proliferation by inhibiting the IL-2 signaling. Further, several corticosteroids are used that acts by reducing the inflammation, thereby inhibiting the macrophage cytokine secretion. Further, certain antibody like the anti-CD3 monoclonal antibody, it acts by depleting the T cells by binding to CD3, and it also promotes phagocytosis or complement-mediated lysis. It is basically used to treat the acute rejection. Further, the anti-IL-2 receptor antibody, it inhibits the T cell proliferation by again blocking the IL-2 binding. Maybe also that it opsonizes and helps to eliminate the activated IL-2R expressing T cells. So this is a little bit details about the complement activation and other factors. So if people are not having any previous idea about it, so you can also comment it into the comment section. Then I'll make videos about the immunological part. Then moving forward, so in another two drugs, so one is the CTLA4 Ig, which acts or the mechanism of its action is to inhibit the T cell activation by blockage of the B7 co-stimulator binding to T cell CD28, and it is basically used to induce the tolerance. Again, moving forward, there is anti-CD40 ligand that inhibits the macrophage and the endothelial activation by blocking the T cell CD40 ligand binding to the macrophage CD40, and this is tend to be experimental. Now moving forward to the another reaction which I've mentioned, which is what happens to the graft when it is implanted or transplanted into the host, and this is known as the graft versus host reaction. So for some instance, the graft tissue, it tends to elicit an immune response against host antigen, and that immune response is known as the graft versus host reaction, which is also known as GVHR. So basically, the graft versus host reaction, it brings several damage to the host cells and to the host, obviously. So when the grafted tissue, they has a certain mature T cells, so they will tend to attack the host tissue, which leads to development or the reaction which is known as GVHR, also which is known as the graft versus host reaction. Further, coming into more details about the mechanism of the graft versus host reaction. So there are series of reaction which occurs one after another in order which results into that reaction. So basically, first the graft lymphocytes, they tend to aggregate into the host lymphoid organs. So this is the first step or the first reaction of a series of reaction that occurs. So thereafter, the graft lymphocytes, they are stimulated by the host lymphocyte. So if people can imagine that the lymphocytes that rat carries, obviously because that is also an organ, so that will have its own graft, that will have its own lymphocytes. So basically, those lymphocytes are stimulated or aggravated or like activated by the host lymphocytes, and after which the stimulated lymphocytes, they of the graft, they tend to produce several lymphokines, which results into several reactions. So basically, the lymphokines that are secreted, they activate the host T cell, which further produces polyclonal B cell activation. Thereafter, the activated B cell, they react with the self antigens, and they tend to cause damage to the host cell. So we can understand that how the mechanism is triggered one after the other. So several reactions occur, but I have in this slide mentioned about the important reactions or the steps that takes place and that results into activation of the B cell, and which results into the damage of the host cell. So B cell plays a major role. Actually, all the components play major role, but B cells, which releases the antibodies, and the activated B cell, they react with the self antigens and they cause a damage to the cells, which is the host cell. Talking about how it happens, which is the host reaction, now we'll talk about what are the several clinical symptoms or the effects of the graft versus host reaction. So there can be either a skin rash, or there can be emaciation, which is also known as becoming thin. There can be retarded growth, certain signs of diarrhea, then hepatomegaly, which is the condition when there is enlargement of liver. Similarly, there can be enlargement of spleen, which is known as splenomegaly. There can also be certain increase in the bilirubin production, and that results into damage of the liver cell, and also increased bilirubin results into formation, or like it results into jaundice. So that is also one of the major problem that is being seen in the graft versus host reaction. Further, even the bile ducts of our body, they are also damaged severely. And further, there is also cases where there is anemia. So, everyone, I have given a brief overview. I think people have got a brief overview about what happens when a graft is like transplanted, or any organ is being transplanted. So this class is very important in order to understand that what happens, like tissue engineering. In case of tissue engineering, I have already given you sessions or lectures and videos on the advantages of it. But it is very important to understand that how it is possible, or how we can manage in order to facilitate the tissue engineering process, and in order to facilitate that other stuff. And with this, I end my today's class, and I hope all of you have enjoyed it. And if you have liked it, please like my channel, and also subscribe it, and also then suggest it to your friends who are interested to get videos and lectures on tissue engineering, regenerative medicine, and its associated topics. So take care, goodbye, and I will see you in my next class.